It is estimated that 57.5 million people worldwide are affected by primary open angle glaucoma, most of who are black people, particularly Africans and some Americans. It forms about one-third of all cases of glaucoma. Now let us know what is an open angle glaucoma, its pathophysiology, risk factors, clinical features, diagnosis and management. Before we begin, please like this video and subscribe to the channel if you're new here. Definition: primary open angle glaucoma is defined by often normal appearing anterior chamber angle and rise in intraocular pressure with no underlying disease. That's why it's called primary open angle glaucoma. Pathophysiology: the IOP rise in primary open angle glaucoma is due to increased resistance to aqueous outflow caused by age-related thickening and hardening of the trabecular meshwork. Therefore, aqueous outflow is slow, leading to progressive rise in IOP greater than 21 mm of mercury, and by so doing it results in characteristic curving of optic nerve head, the optic disc. Risk factors: the risk factors for primary open angle glaucoma include heredity, age, race, diabetes, hypertension, and myopia. Heredity: the risk of having the disease is higher if the siblings of the patient are suffering from the disease than if anyone in his or her parents had. Race: it's more common and more severe in black people than in white. Diabetes: it was found that diabetic patients have a higher risk of primary open angle glaucoma than non-diabetics. Age: primary open angle glaucoma is more commonly seen in elderly patients of 50 to 70 years. Hypertension: likewise, risk of primary open angle glaucoma is more in hypertensive patients than in persons with normal blood pressure. So also myopes are more predisposed to primary open angle glaucoma than the normals. Clinical features: like in all other types of glaucoma, patients with primary open angle glaucoma cannot know that he or she has glaucoma at the beginning until it causes a significant loss of peripheral vision, less if the patient undergoes a periodic eye checkup. However, patients may experience mild headache, fluctuating pain, blurred vision, and more importantly, hairless around lights, which is more worse at night. Diagnosis: now, how can you as a doctor diagnose primary open angle glaucoma? The first step is direct ophthalmoscopy using an instrument called ophthalmoscopy to examine the likely changes in the optic disc such as the curving of the disc. The normal curve-disc ratio is 0.3 to 0.4 and anything above that is considered glaucomatous. Other changes we may observe on the disc include foul areas on the disc, splinter, hemorrhages, or even optic atrophy in advanced cases. The second step is tonometry using pulse air tonometer or an affluation tonometer to take the IOP. The third step is perimetry, which is a visual field assessment test to check for peripheral vision. Management: the aim of the management is to reduce the IOP. Treatment is usually started if the IOP is greater than or equal to 24 mm of mercury. The first treatment is achieved by using drugs that increases aqueous outflow. These drugs are called prostaglandin analogs. Example, latanoprost. The second treatment is by using drugs that decrease production of aqueous humor. These drugs are called topical beta blockers. Example, estimolol. Carbonic anhydrous inhibitors such as dorzolamide also reduce production of aqueous humor. The best of all is the third treatment, which is achieved by using sympathomimetics such as brimonidine or misoft that decrease the production of aqueous humor as well as increase aqueous outflow at the same time. Where eye drops are ineffective, surgical techniques such as trabeculectomy may be used. It is achieved by removing some parts of trabecular meshwork and adjacent structures to make a new way for aqueous humor to drain away from the eye. Thanks for watching. Please help us subscribe to the channel for more videos of this kind. See you next.